Hi, everybody, and welcome to this episode of Tough to Treat. We are welcoming Elena Newell, Rockstar PT, who is bringing us a very interesting case of a complex individual that came to her for one reason, but quickly unfolded into many reasons why his movement pattern and pain experience have been so complex. I hope you enjoy the episode. At this time, it is starting to become mid-March, and Erica and I are hoping that the weather in the Northeast quadrant is beginning to break and expose itself to spring for us. As always, let us know what you think. Join us at www.toughtotreat.com. Leave us any messages that you want, or you can also email us at any time. Thank you very much. Enjoy the episode.
Hello, everybody. This is Susan Clinton, along with my partner, Erica Meloe, and we are Tough to Treat. We are really glad that you're here today with us and listening in on the podcast. Today we have a physical therapist, Elena Newell from Denver, Colorado, who is joining us today as a guest to talk about one of her Tough to Treat patients. So welcome, Elena, to the podcast, and tell us what you have for us today.
Wonderful. And thank you guys for having me here. I've definitely been a long time listener. And when you said 40 episodes recently, that's kind of hard to believe.
I know, it's crazy, right?
So the gentleman I bring you today, he is a 61-year-old male and he has a long history of low back pain. He reports having a very athletic history. You're Colorado-based, so people are athletic here in general, but he's been a skier since he was a kid. He played semi-pro tennis, semi-pro soccer, hockey, and reports having care along his way of his career, but nothing substantial. Until about 15 years ago, he reports rupturing his L4-5 and 5S1 playing hockey. And right after that injury, he did have a microdiscectomy and a laminectomy. He reports he had major complications after the surgery, and he said he had these persistent stitches that they couldn't figure out where they kept coming from or why I kept having issues, but they kept opening. And it figured out after a couple surgeries, they went back in and figured out he had a pretty severe staph infection that just never cleared through. So his perception is that they've just taken out a bunch of tissue in that area. He doesn't know particularly what was taken out, but when you do look in the region, you can definitely see at least part of his paraspinals was removed at the time, but it's 15 years ago, so his tissue is kind of taken some of that space again. He's coming to me at this point from a general surgeon who does a lot of abdominal surgeries, and so he had gotten to that gentleman because he was having abdominal pain, and he thought he had a sports hernia. This physician's pretty good at differential diagnosing some musculoskeletal stuff. So he'll often send them to me if he knows it's not a surgical type of case. And this gentleman said, well, I don't know what you're really going to do for me because he says it's it's still, I feel like I have a hernia. And we'll talk about what his abdomen looks like in a moment. So he really wasn't coming to me for his back pain. He was coming to me to help figure out what the abdominal pains were, but I was feeling that they were pretty related. He would like to be able to increase his fitness level. He figures that, 5 years ago, he was a lot more active. He was riding his bike. He was doing things. In this past 5 years, he's really kind of gone downhill and is really dependent on providers to help him out. And so he currently, and I started seeing him in July, so it's been just a little over 6 months. At evaluation, he was getting biweekly deep tissue massages, biweekly PT, who is primarily, he was saying that they primarily just do dry needling into his glutes and into his lower extremities. He was also seeing a chiropractor. The frequency in which he would see him would vary, and we'll talk about that. He has a sensation he says calls popping out. So every time he pops out, he goes in to see the chiropractor puts him back in, and he kind of moves on. So he would see him anywhere as upwards of 4 times a week, minimum at least once a week. In 2016, he had 12 injections. Primarily some in his cervical spine, C2, C3, C4, C5, as well as lumbar 4-5, 5S1 is again. He reports it as a constant pain, and he reports it as a constant pain, but the abdominal pain seems to come and go. He doesn't feel like the abdominal pain's constant, but he notices if his back is out, his abdominal pain will be worse. So his current activity level is he's currently not working in a desk type of setting. He's doing more of a volunteer work at this point. And so he volunteers with the canine program locally. And so he helps train canine dogs to help support police work. And then he does do as a volunteer base, does do like drug operations, but it's kind of intermittent. It's not like a 9 to 5 all the time, but maybe once or twice a month he'll go with his dog and do searches and support different kind of rural areas. So he definitely walks his dog on a daily basis. He has 2 of them. He walks 4 to 5 miles a day, and he notes he doesn't have pain with walking. He can walk all day, but he would like to be able to do other things, right? Having played soccer, he kind of goes back to his soccer days. He goes back to his tennis days. He's kind of given up on the hockey and skiing piece, but he would like to be able to do, at least ride a bike, he says. His other big goal is to be less reliant on other practitioners. So I didn't mention that the chiropractor he sees multiple times a week, he drives about 45, 50 minutes to go see him. And so it's a big kind of burden in terms of like the amount of time it takes during his day.
Oh gosh. Do you want to go, Susan? You want me to ask a few questions?
I'll let you start. Go ahead, Erica.
Question. So does his abdominal pain, how long has he had that?
He says the abdominal pain's been intermittent, but he notices it's been worse the last, it kind of puts things roughly in the last couple of years when he feels like he's gotten less active and he's gained weight. So he said he's gained about 25 pounds over the last 4 years. And so he notices with the weight gain, he feels it really in his abdomen. And that's kind of where he kind of feels it's been worse, that prompted him to actually do something about it.
Where in the abdomen? Like upper abdomen, lower abdomen?
Right at his umbilicus.
I think you mentioned that. Okay, umbilicus. Okay. I had a bunch of other questions. So does anything the abdominal pain, does anything make him feel better? Has he been tested for food sensitivities? I'm sure you've asked that, right?
Yeah. So his diet's pretty clean. He does well from that standpoint. He has not been tested from allergies, but from everything I can gather from it, doesn't feel that way. He does a kind of a funky thing that every year in January and February, he takes 2 months to completely clean out his diet, including he removes all alcohol, all inflammatory foods completely. And he says it helps some, but then it's still present.
Okay. So when he had the injections, why did he have them in 2016 in his neck, in his C-spine?
He says he's never had any surgical intervention on the C-spine, but he's definitely sustained a lot of other orthopedic injuries as well. So he has had imaging showing C2-3 as well as 3-4 both have disc issues. And so he was trying to rule out his pain and thinking if he had injections, they could identify which nerve was having an issue, and then aka his pain could get reduced all the way. The one thing he says is the injections didn't really do anything. He didn't have any symptom relief at that time, didn't change his course of action, so he hasn't had any surgery or anything additionally since then.
Okay. And any kind of increase in fitness level, like can he ride a bike without back or abdominal pain, or is that something that aggravates him?
He's definitely somebody who often will live in the past of things he used to do. So the most recent he can tell me that he rode his bike was about 5 years ago, but I can't ever get him to tell me why he stopped. Like he seems to not remember anything that particularly happened that then changed that course. He just says, "Oh, I got lazy," and it's hard for me to believe. So I think some of these happened, but he's not remembering the incident.
Right. No major trauma, no significant falls or anything like that.
He was a hockey player, so he definitely fell a fair amount over his life, and skiing, but not any one incident particularly.
Okay. Susan, you go ahead. I have a bunch of questions more, but you go ahead and
Sure.
chime in.
Some of my questions are going to be related to, has he had any other illnesses other than this staph infection? That obviously a staph infection, especially into the spine, is a big deal. That's a big deal to the system. Has he had any other illnesses since then, like major illnesses?
No, he actually usually prides himself on being pretty overall healthy, except for his orthopedic issues.
Yeah, and you know, there's some things that are striking out to me here. Somebody who is chasing their pain, which is what this guy is doing, you know, and
Yeah.
can't blame him, right? He's had a lifetime of being very active and in sports that are, you know, you're going to participate in them, you're going to get hurt. That's just the way it is. But I'm just wondering about, it sounds like to me that there's probably a history, or maybe a history of multiple concussions here. And that's going to be a problem with his stress system and his stress response system, because it's probably never been mitigated the right way, correctly. The staph infection is a big deal. You know, every time I run into somebody with abdominal pain that nobody can figure out, generally comes from some sort of illness or major injury that has set up, you know, the stress response in the gut. And it's telling that, you know, he goes, you know, through his stuff and he can get rid of most of the foods that bother him. But it doesn't make him feel totally better. And the main reason is that when you go on an elimination diet, if you've got abdominal issues, whether they're digestion or just a visceral sensitivity, you have to be you got to get on the train for longer than 2 months. It just isn't going to work. So jumping on and jumping off makes you a little bit better, and you can kind of carry on or soldier on, but you're not really going to get to the crux of the problem until you get rid of the inflammatory, whatever's causing the GI inflammation for a long period of time, and be able to get that to settle down. So the other question I have is on his bowel movements. Did you talk about his bowel movements with him?
Yep. So he is actually, he's really good from a bowel standpoint. He has at least, if not 2 bowel movements a day. They're soft in form. When we first started working a little bit, he was straining with them. Some minor adjustments, we seemed to be able to get him to take that away. But he never knows, no urgency, no incontinence. Actually seems relatively decent from that standpoint.
So yeah, so he can be, does he feel better after he has bowel movements?
He does.
Yeah, that's a hallmark of you know, it sounds like that this is, you know, what this is saying to me is that you know, the overlying, well, kind of the expression of what's happening now, besides his orthopedic issues, is this irritable bowel syndrome, which is actually, that is the hallmark of irritable bowel syndrome. Is, you know, it started off with some disease or some, you know, illness, like super illness, and this staph infection could be one of those. The history of concussions, I think, is huge. And the fact that he feels better after his bowel movements, that's a hallmark sign. The visceral sensitivity is the piece. It's good that he's not as constipated as he was, which, you know, his system can change, and that's wonderful. But I would have to almost say that this is probably what is more driving his visceral sensitivity, way more than a hernia of any kind. But I'll wait to kind of hear what you have in the eval. Erica, anything else?
You know, I agree. I agree wholeheartedly, and especially with hockey. You know, I mean, they're getting hit, they're getting back checked, front checked in the thorax, and you've got that whole sympathetic system in there. I mean, with all the surgery, the infection, the tissue removal, the injections, he's got to have some scarring along the dura too, in terms of his entire dural system. So, depending on you know, what you found in the eval, the body just. I had a patient similar, not with his crazy history, but who had abdominal pain, and I mean, her entire body, it was just trying to right itself from a dural standpoint. You know, she would untwist her thorax or pelvic just to feel better. So that is, I would probably point the finger at that his history, in terms of traumatic history, as also being a part of it. So I would agree wholeheartedly. So what did you see in the eval in terms of the objective?
Yeah, so I think it's one of those guys that you kind of wish this wasn't an auditory thing, because if you were to see him in a crowd, you could easily point him out as a guy that something's going on. From the standpoint, when he walks in my office, you almost think he's a robot. So he has no rotation, no extension through his pelvis at all. So as he's walking, I feel like Arnold Schwarzenegger almost walk. And then when he's standing, like I give my patients the option of, do they want to sit, they want to stand, lay down as we're interviewing. And he always wants to stand. He will not sit. He does not like sitting at all. So he's standing there, but he kind of gets himself braced. So he takes an extremely wide base of support, and then he crosses his arms and kind of locks his chest. So he's pushing his abdomen a little bit farther out as he stands there.
Also a protective mechanism.
Yes. Yeah. So I was like, well, we'll see where you're at. Yeah. No, it completely was. Like, it was you could tell it from a mile away. I was like, okay, this is what we're doing here. So that's kind of where he was standing. When I had him move, he reports that he's not fearful of his pain, and we've talked about that over time, but he wouldn't be willing to do certain movements. So he won't, at eval, he would not rotate. He'll straight up, flat out say, I will not rotate. That's something I can't do. That will always make me go out. He is willing to flex to an extent. So he'll go about, I think he is about 50 degrees. He'd flex forward. He'll extend. So he'd extend as far as he physically can. He is relatively rigid throughout his whole skeletal system, but he can extend decently. He'll side bend about 10 degrees max. After that, he just stops. If I try to provoke him to go farther, he gets very fearful and kind of pushes a resistance against it. He does also, I didn't mention, has a rotator cuff tear in his left shoulder that he'll go overhead, but he can't do repeated overhead. So from an upper extremity, like neural tension standpoint, nothing really pulled out. It actually, from his cervical spine, seems to be relatively stable. He doesn't seem to provoke it very easily. So didn't have any positive neural tension on the upper extremities. When he's definitely a positive slump bilateral, relatively fast. So I don't even have to provoke the lower extremities to induce anything. What else with him? With his abdominal pain, it was interesting because I definitely wanted to get him on the table just to see in a different position of what his abdomen was doing. And so how he goes from standing to sitting, and then especially from sitting to lying, is a very interesting maneuver. He essentially holds his breath and kind of tucks and then flies himself back. So it's almost as if he's sitting and then takes himself into a horizontal sitting and then will let his legs go down. Does that make sense?
Yeah, so it's almost like a log roll, but in reverse or something. Yeah.
Yeah, but he won't fully log roll because he won't go onto his side.
Right.
Yeah.
Yeah.
So when I got him down onto the table, and even as he was doing this maneuver, I'd asked him if that caused any of his abdominal pain, and he definitely says it does. Every time he does that, it hurts his abdomen more. And he has a pretty significant DRA present. And essentially, as he valsalvas every time, he hasn't figured out how to breathe and transition. So that's actually where I kind of started with saying, let's figure out how do we get you to move a little bit more gracefully, but figure out how to move with your breath. And so his abdominal pain actually went away relatively fast. After, I think it was 2 treatments, he reported he really wasn't having abdominal pain anymore. Once he started to learn how to use his core and breathe with his transitions, the abdominal pain seemed to go away pretty fast. And so I think that's actually why he's willing to stick with me a little bit, is because I was able to get that quick of change. So he's thinking, oh, maybe she can change my back as quickly, which I knew that was not quite going to be the same story. When I was looking through his abdomen, he definitely had a lot of muscular tension. His bowel actually was less inflamed than I was anticipating, but we did start with some colon work and getting him to do some home colon work, but also the biggest thing was I had him start to do breathing in different positions. And that actually seemed to mitigate his abdominal pain pretty frequently or pretty quickly, but he really had kind of gone back to this whole back pain issue and wanting to not see his practitioners as much. He is very fearful of laying down. So he'll do it because he knows he needs to lay down to sleep. So he will sleep in a bed, but he's fearful of moving in bed and then getting out of bed. And that was definitely like a very provocative time for him, was between those two different transitions.
Elena, did he, was his abdominal tone different in standing than in supine?
He, in general, I feel like he wasn't breathing from the standpoint of he would almost bear down in standing.
Okay.
To give himself some stability.
Okay. Like. Got it. And then the colon work, that's not my, I don't do that. Just explain to me what that is that you did.
Yeah. So I usually start from a out to inward approach, standing with, can we do some muscle release, get some breathing. So that way the external aspect of the abdomen softens up a little bit and reduces that guard. Yep. And then I did definitely do a visceral assessment, going through large intestine, small intestine, bladder mobility, checking diaphragm from that standpoint, and then kind of started to do some visceral manipulation just to get things moving in a direction. And
that did help him?
A little bit. Yeah, he thinks so. He really felt like once we actually got his abdominal guarding down, that's what took the pain away before the actual visceral work.
Okay, so the thing that you've done so far, at least was the breath work that had helped him the most in the first two treatments, correct?
Yeah, absolutely.
Okay. Got it. Susan, you can go ahead if you have
So, no, I totally agree. That's the first thing I do is the breathing. You got to get them to where they can actually bring their stress response down, and the visceral mobilization and abdominal wall mobilization is, working on that viscerosomatic connection, which is, with a sensitive gut. That's how it expresses, and you get a lot of abdominal gripping and, different things. It sounds to me like in standing, he was using his diaphragm as his postural control mechanism, which is why he was bearing down, cross your arms kind of thing, because he didn't have any other strategies to use. Before we go any further, I have to say the other thing that sticks out to me in such a huge way is the psychosocial component of this. Whether he wants to talk about his fear, he is afraid. And movement, this kinesiophobia is huge with him. Does he have any counseling support?
He does not. We talk about it almost every time he comes in. He's still very resistant of it. Last time I saw him, and right now I'm only seeing him like every 2 to 4 weeks-ish. And every time we bring it up and every time I go there, he's starting to be a little more, he's not discounting it right off the bat at this point. When we used to talk about your pain and why you're going to the practitioners, he'll even say, well, I don't really have pain. I just don't want it to go there. And so I feel like he's starting to get in that direction and willing to change, but it's definitely a huge piece that I realize is probably why I'm still seeing as much as I still do.
Yeah.
Yeah, it's when you have this type of kinesiophobia, it's really, really, it's a huge barrier to movement. It really is. I don't know what you've done with any of the pain education piece for him. If he has resources or if he's actually been willing to look at resources and look at things. When I run into somebody who is running this hard against movement, I generally tend to back way off and start in the beginning with David Butler's stuff, and I just go straight to the Recognize app. And with him, I would start with the back, but you might even to pull out of that even a little bit, to not even go straight to the source, is he's had some neck issues or some shoulder issues. You could start with Recognize Neck and let him get started with that, where it's a little bit easier. It's an appy, but that's going to at least bring him across midline through his brain, working, and start dealing a little bit with the brain smooching that's going on here, because that's what it is. It started off in his back. He had this tremendous thing that happened. He's had this fear of whatever that popping out thing is that somebody has put in his head. Somebody told him never to move in a certain way, so he's planted that firmly in his psyche. And I think you're gonna have to kind of back away a little bit and maybe try to approach some of this from the psychosocial point. Like I say, maybe even getting I don't know if you've ever heard of them, but they have cards that are called FODRA and PHODRA for those who are listening. And they actually have, it's kind of like the Recognize app in many ways, but you can use those and just say, I do it a little bit like a bit of a card game, like pull out the ones that worry you the most. And it's functional movements is what it is, cards of that. So that can kind of help a little bit. And it's like, I know you're not afraid of your pain. You've said that you can reflect that back, but you're afraid of movement. And I know why, and I hear you. I understand why you're afraid of it. And, just kind of acknowledging that and kind of moving forward, because the things he wants to do are the things he's unwilling to do. He wants to ride a bike, but he is unwilling to sit.
Yep.
So, that the bike isn't going to get there anytime soon until his willingness to kind of move into some of these positions will begin to change. And he's been doing this now for 15 years. It's a long time to have developed this. So anyway, that's just my 2 cents throwing in right here. Erica, do you have anything you want to add before Elena goes on with some of the other stuff she's done and worked with?
Yeah, no, just when he walks his dog, he has to have some rotation because he has one hand on the leash. So he's got, I think it's so important because of the rigid posture he's adopted that what's the word? It's going to affect the pressures in the system ultimately, and I think that as you both know, so for the listeners, I think that, beginning with the explained pain and the psychosocialist part is so paramount, but ultimately at the end of the day, he needs to have some movement and decrease the fear of movement. So it's not a question per se. It's just that would be for me, with the obvious, psychological issues and, it's that rigidity, that unwillingness to move. Like you said, Elena, he doesn't really have a ton of pain, but he's afraid to move because for whatever reason, we don't know. So that's just my 2 cents there. So you can go ahead.
Yeah, I think, Erica, I kind of went on your line because after a little while and getting frustrated from the standpoint of him not really wanting to go there, I was like, fine, we'll just go do stuff. We'll just move and see as time goes if he'll be willing to come back to that a bit more. So I really did start with knowing he was more comfortable in standing for now. I started a lot of our movements in standing or a de-weighted position. And even just to get him to de-weight, like pulling my high-low table up as high as it could go and having him on elbows, that was even a fearful for him to do. And so it took us a couple of sessions to get him to be willing to do movements in there. So we kind of just started to say, okay, let's just get in, let's just lean on here and see what this feels like in some side to side or some weight shifting. And then started to try to do some spinal movements in there. So I often use that, depending if people won't get on all fours, use that as like an in-between how to get some spinal movement to go. And he's really improved drastically of how far he's willing to move through there, but in a very limited context. So he says he's willing to do it with me in the clinic. I would say just in about the last month as he started to do them at home, because he was, again, afraid of if I do it at home, then am I going to throw myself out and start my whole cycle again? So we started from that standpoint. We've done a lot of walking-based things, big steps, long steps, wide steps, turn your feet different direction steps, backwards walking, sidestepping, even kind of got him to do some more rotation with holding a ball and rotating. So almost doing like a march rotation and then doing grapevine. That was one that actually got him to do some rotation with. And so his movement patterns have drastically increased. His gait speed's actually increased by like 0.3 meters per second, which I assumed I wasn't going to make that much of gains with him, but just getting him that AP motion, I feel like really started to help versus being so lateral based. Oh, and Erica, based on when you said he has to rotate to walk his dog, it's a canine dog. So I've never seen a dog so ridiculously well, like slacked on a leash. Because the dog comes into the office with us.
Oh.
And so, no, he does not. I was like, how do you not rotate? You walk a dog.
Right.
Right? Yeah.
He must keep him on a real short leash. That's crazy.
Like he has on a short leash that has like slack to it. The dog's amazingly trained.
Wow, of course. Yeah.
Yes.
Doesn't have, yeah, the dog, I guess it's funny because I have a lot of patients who walk their dog who have back pain, and it's all of this with the hand, with the rotation. So if he's not moving, he must have a very rigid,
completely.
Yeah. So yeah, very rigid issue.
And I don't think he realized like he had no rotation from the standpoint of no arm swing even. So now when he walks, he actually does have quite a big arm swing. Where we're kind of getting stuck now is that anytime I try to get him to do something to use his gluteals or his posterior musculature, it automatically throws him into feeling like this giant muscle spasm that kind of puts him on the road to think he's going to go out. So I've tried doing a lot of different glute activation exercises in every position, but it really seems like as soon as he gets a couple reps in, but then he starts to overuse his back musculature. And I really kind of am like hitting this roadblock of figuring out how do I get him to get more strength from there to actually move forward, or should I even be trying that at this point? He definitely, like when he sees the other therapists and they needle into his glutes, they always say, oh, your glutes are chronically really tight and spasmy and irritating. And I'm like, I don't really care. But it's how to actually like get him, because I feel like his one thing he's really lacking now is a lot more of his power and like how to push up, how to, we can do a little bit of squatting, but he'll only go a little bit because like he compensates of what he's using so much.
Right.
Mm-hmm. Yeah.
So 2 thoughts on that. I totally agree with, that his, it's probably not his glutes that are over recruiting, but anyway, that's another whole podcast. So this is some of the things that I would do. First of all, I love the rotation that you're getting him, and the fact that he will even be willing to do grapevine, which means he'll cross midline now, which is absolutely huge. The other thing that I would pull in with him and immediately would be getting his eyes moving and working. This guy is still, if there's a post-concussion thing going on here, part of that could be the reluctance to movement that he doesn't even know he has because the balance system is so locked down to keep him from having symptoms. That was the only way he could keep doing all the things that he did all those years. Getting the eyes movement, I think, is going to be key, because when you start rotating the eyes, the cervical ocular reflex is going to start to kick in. And that's going to help him start even prefrontal cortex stimulation for rotation from somewhere besides the area that's under threat, right? Like he does have some stuff around his head and neck, but it's not as, he's not as afraid of that as he is of his back. Getting the, and then, following maybe with some C-spine movement. There's a great app out there called Clock Yourself. For all the listeners, I love this app. It is amazing because it's all reactive. And it does it on a clock, so you stand in the middle of the clock and you can move your feet. But the cool thing is that I tell people to take that clock and put it on the wall. And then they move their eyes to wherever the clock is. It's an imaginary clock. You can actually put stickies around if they need to have targets. And so then the clock will say 2 o'clock, and they have to look up at 2 o'clock, down at 5 o'clock, over at 7, over, right to 3. And they can do that while they're, working on balance, and they can do it standing on 1 foot. They can do it standing on 2 feet. They can do it standing on a piece of foam. You can kind of work some things up that way that can kind of start to help gather and start to get some variance around that cervical ocular vestibular reflex, which, when a system is under threat for so long, that system really does lock down. And I see that constantly. And it's kind of a nice way to begin to introduce those movements and the changes through, because that'll start changing the trigeminal system and start, getting him moving even a little bit differently without saying move this way, which he's afraid to do. So it's kind of like skirting around the protective brain and getting into, some movement variances that can be super, super, super helpful, and can, bring rotation into his system without him even realizing that he's rotating, because it's occurring, kind of through the central mechanism rather than, through the exterior or the peripheral system. And, you know, the other place, and you've already started hitting on this, which is great, is his ability to start to move through his feet a little bit. And I would bring more attention down to his feet. Like, are you on the outside of your feet? Are you on the inside of your feet? Can you sway outside, inside, forward, back? Can you sway around and around? So that he has to start letting go. And Erica always talks about making sure that they're not gripping down into, so I would be working with this guy barefoot to see what's happening at his feet, so that, you know, you could get in there and you could just get a hold of his toes and just say, you know, I talk about the 3-pronged foot, like you know, a lot of our listeners are yoga practitioners as well. And I've learned much from them, you know, but the heel and underneath the first metatarsal and the fifth metatarsal, you know, the head's there, and really pronging that down, but those toes really coming out long and learning how to really let those toes go and how to lengthen them and change those, because probably what you're going to see when you take his shoes off is, I would imagine that he's gripping like a crazy person. And that's part of that whole, like you just explained with his posture, is stand, feet weight apart, cross the arms, you know, tough man posture, like don't come near me, don't make me have to hurt you, you know, that kind of thing. And so along with that goes those, you know, really super grippy toes. And that's part of all that neural tension system in there too. So as far as the glutes go, though, my thoughts are, and I love the fact that you've tried to get him squatting some. You know, those, you can do it with TheraBand. It's just that the TheraBand rolls, so it's kind of hard to do, but you kind of get what I'm getting at. You know, I like those long elastic bands like they have in the gym. They're probably like about, I don't know, maybe 2 feet long or 3 feet long, and they're a heavier material, and they give, and you can hang one of those up. And I actually have the person put it underneath their ischial tuberosities, and I make them walk backwards till they get to the point to where there's some stiffness in there, so they can start. And I have them put their arms up on it and hold, you know, and it's wrapped around something steady, and they can begin to learn to sit and push into that, so you can start to get his glutes activating and, you know, things happening with a straight back, so he's not afraid and he has control. And and once he gets used to the fact that will hold him and it won't give out from underneath him, you can actually get people to start really going into some decent squatting. Mm-hmm. And that's really a cool way to work with that, to, you know, to help to start to get that, because he's got to get those hips bending, and those hips should bend beautifully, but, you know, he just hasn't coordinated that pattern or that movement for a long time.
Like a TRX, Susan, holding on, or the band's under his bum?
The band's under his bum, but he can hold on to a TRX too. Whatever, you know, he may feel more comfortable, like holding on to like the grippy thing and not putting it underneath him in the beginning. Yeah. I have people grab hold of doorknobs. Yeah. Like open a door, grab the 2 doorknobs, feet wide apart where he's comfortable. Let's start bending down from there. And they can still control their trunk, but their arms are straight onto the doorknobs. And that's a kind of a cool place to work too. So all of those are good. And I love the fact that you're actually trying to get him into that. But those are some ways to do it without perhaps his back muscles, his, extensor muscles, feeling like that they've got a grip on and guard and hold the farm still.
So we've done something really similar to that. So I'll use like the highest resistance TheraBand we have, and then have like the wall anchor ones and have them go into it. And he's doing pretty decent with that one. It seems like, though, as soon as we make it like any open chain, from the standpoint when you take his feet off the ground, then he's not able to carry that movement over. Right. So if we try to do like a similar thing, but maybe like a back step or a slide or anything of where the leg has to move, that's when it seems to trigger it, versus if I keep him grounded through the floor and through the arm contact, he does okay. As soon as it's a little more open, that's when it's like he falls apart in about 4 reps. Usually you can get to like 4, maybe 5.
And are you doing those in standing?
Yeah, that's my question.
So have you tried him, since standing is good for him, you could use the corner of a wall or something, so he could put one hand on the wall in front and his foot on the back, and he can put his foot up on the wall behind.
Yeah.
So he has 3 points of contact rather than just 1 point. Yeah. But I think, really working into that balance system will help, because I bet you $100 that his balance system is what he's battling.
Of course,
when you take him into open chain. Yeah, when you take him into open chain stuff. Yeah, so that the 3 points might help. to
Yeah,
get
okay.
him to like push, because I know, like kick back that foot into the wall, or,
Mhm.
just even be willing to bring that foot up and put it on the wall, with the hand in front, so that he can, so that he has something to work with or work against.
You know what you could I'm sorry, Susan.
Go ahead. No, go ahead, Erica. I'm going to let you chime in now.
No, I agree with, I think those are fantastic. So you're saying that when he does an open chain backwards, like backwards walking, he's kicking in his paraspinals?
Yes.
Okay, so.
And even if we do it like just standing stationary,
Mhm.
Okay.
we've done it like with a slider, we've done it non-resistive bands, we've tried to put some tension, like have a lighter TheraBand around his foot as he pushes back to give that feedback.
Got it.
And even, like those will all kind of kick him up.
Trigger. And so you're saying, and he recognizes that like 4 reps, he's doing it.
He does. Yeah, he can feel it. And then that puts him back into his fear avoidance. Like that's the pain that triggers him into, oh, I need to stop what I'm doing. I'm about to hurt something.
Yeah, so I love the 4-point into 3-point. I think that's a great way to grade the movement.
Mm-hmm.
So we're assuming that his issue is fear of movement at this point, like his diagnosis, quote unquote. So what I have found that, and this is my experience, that when I'm sort of plateauing with an exercise progression, I talk about this a lot because it's made such a big difference in my practice, are the issues of these self-checks. So and these reset exercises. So with him, does he have one movement that he could do besides maybe backwards walking that he could test himself out with? Like I tend to do like a one-legged standing or a squat. Does he have something that he could, if he goes and walks for 4.5 miles, that he could check to see if something is not right in his system?
Yeah, that actually pretty, like his forward flexion is bend forward.
Okay, so for example, if he goes and walks 4.5 miles, he's pretty good with that, and he bends forward, he feels okay.
Yep.
Okay, so after backwards walking for 4 steps, can you check his lumbar flexion?
Okay. Yeah.
And see if that is like worse, quote unquote. If it is, which it probably would be, if that's his like a good self check, then you would have to, what I call, I use a reset exercise to progress the system. And from what you're telling me, what I would choose based on what you said, his reset could be these squats, because he's doing them with fairly good control, right?
Yeah.
So if he goes, and he's not afraid to do them. So what you could do is you can, no matter, even if he goes and sits or he walks his dog or whatever activity he's doing that's somewhat new, I would have him sort of do his self-check and bend forward. He may feel great, but there could be something he's doing throughout the day that could be setting him off a bit. And I do think it's fear. However, if you can empower him by giving him this reset, a good movement that he can do well, then his fear will eventually go down, and he can pinpoint certain activities that will set him off, because he's not seeing you, like 2 times a week at this point. So that's what I would add. He needs to have a reset. He needs to be able to do something to take his symptoms away and decrease his fear. So that's what I would start with. And then, and as he moves on, if he starts to plateau and he does, for example, the exercise that Susan mentioned, the 3 points, and he does that really well, then that would be his reset. The failure of a patient to progress in exercise, in my opinion, is these lack of reset exercises, or the lack of a progression. So he keeps doing squats, he's good, but then he still can't, sit
walk
for
backwards.
20 minutes. Exactly, walk backwards. So he needs a 3 point. He needs to go from 4 point to 3 point. So that's my 2 cents, because I found that it's something in the progression. It's something they're doing or thinking in his case.
Yeah, and then adding in the richness of getting the eyes going and the C-spine as you can, and because that's another way to gain rotation through the feet too, really getting those shoes off and taking it. Tell him to exercise without his shoes on. For one thing, if he can move around his house without his shoes on, that can be a real big thing, because he's not getting input from his foot in a different way. And you take the shoes off, the input that comes in is different. So the brain has to pay attention to that.
I'd
which
say
is
he
good.
actually
Mhm.
he's probably almost the opposite. So, and maybe it's a big Colorado thing, but people wear minimal shoes here as much as possible.
Mhm.
So even like if I were to see him this week, he might be wearing a closed toe real shoe, but he's usually in a sandal type of shoe. So he actually doesn't wear them when he's home. He's barefoot most of the time. So his not as grippy through his foot as I was anticipating. But he kind of just doesn't move it, right? It's pretty rigid versus
Right.
actual gripping.
So those long toe things can really
yeah.
work as he's kind of walking, since you're working on walking with him and changing his walking, just really
Yeah.
making sure that those toes are really like stretching out and lengthening and not curling through different parts. And he'll be able to feel that. And then the last thing for me is like, I would get into the Recognize Back or the Recognize Neck app and get that started, because that's the first part of graded motor imagery to overcome kinesiophobia from David Butler. And then, when he's ready, you could work him into the Protector Meter book and let him start kind of reading that, or one of Adrienne Lowe's books, Why Do I Hurt? Or Erica's book, Why Do I Hurt? She's got a great book out that can, speak to, sometimes people think it's this and they realize that it's this, so there's, some other different resources that you can give him. I think another great resource, for him to kind of just take a closer look at, if he wants to do something more around nutrition, because it sounds like he cares about that a bit. I think Joe Tata has a great chapter on gut health issues and pain. It's his book about pain, but he has a very nice chapter on that that's easy to read and understand for people.
Yeah. You know what, Elena, I would also, because he's a back gripper, so this is his issue and that's his strategy. Can he get into a child's pose or a down dog position at all?
We haven't tried, and I didn't mention he also has one of his knees has a lot of meniscal issues.
Right.
So we haven't done tons on his knees. So we've done like a modified down dog on the counter.
Okay,
but
good.
We haven't gone all the way down.
Okay, or you could, because it's a great way, especially with the thorax, because he needs to get movement there, and you can have him you can even make that a reset if that helps him, against the wall, and just do some lateral costal breathing against the wall at 4 points. It's a safe position. Yeah. Have him do lateral costal breathing because the breath work helped him. So if the breath work helped him at the beginning with this abdominal work, the breath work will help him in the end with his fear. So and you've had good results with that. So I would bring it back to that, because that's helped him, and that'll help throughout, no matter, what level of athlete he wants to, or anybody, but do it in a safe position. The safe position is the 4 points at this point, right? So I would, start there and break it down to 4 to 3 to 2 to 1, but give him the resets and the self checks to get him more empowered, so you can report back when he sees you in 2 to 3 weeks. And so you can really hone it down. I would also, because of the history of concussion, this is my thing. Have you done any manual work at all on him in like cranium or anything like that?
I have, yeah. I'm trying to remember. He definitely has a lot of like suboccipital tension, like that's pretty taut through there, but his cervical range is pretty decent. It's hard to provoke any cervical symptoms out of him.
Okay.
But I haven't tried a lot of like the vestibular ocular stuff, so I haven't really tested the system.
And whether or not he has post concussion or not, that system has not been working for 15 years, and probably before that. Yep. So that's something that really needs to come in, because the richness of movement and the changing and the stuff, people don't realize they have that until they start challenging it.
Yes.
So it's very, very interesting, and that'll be something that I think would be really good. He probably one other question I would find interesting for him, does he insist on driving himself everywhere, or does he not like being a passenger in the car? Because people like this will tend to drive themselves and never be a passenger and never sit in the back seat. And they don't like mass transit because they can't be in control. So in the car, they can have their hands on the wheels and their feet on the ground, and they can control it,
Yeah.
Whereas when you're a passenger, you kind of have to be much more reactive, to what's actually happening, the bumps and the turns and the stuff. So that's
really interesting because like he does drive quite a bit, right? His Cairo's a good 45 minutes away. Like I'm almost an hour from him.
Mm-hmm.
And so he cares for his mother somewhat, and she's a decent distance. So he's driving all the time. But when he mentioned going on a trip for one of the canine trips, he was so terrified to go into somebody else's car that he related it to the seat. And I guess I didn't even think twice about that.
Yeah.
Great point. Yep. Yeah, that's very interesting. Yeah.
Yeah, because he kept saying, "Oh, it's going to throw me off," and it was an issue.
So
he recognizes it, but I don't think he recognizes
for the
why.
reason. Yeah, well, and he wouldn't, right? Nobody, he doesn't. He's a strong, upright guy.
Yeah.
I mean, he's obviously extremely resilient. He just needs variance around that, stuff to really, help it, and a bit more self-efficacy, so that he can, really be able to, have a better understanding and once, just to be able to be a bit different. But that, oftentimes those kinds of things, when I hear those stories, that really drives home to me that there's something that has gone on, and whether it just hasn't gotten cleaned up out of his, deeper system yet.
Yeah.
And you can do him a lot. He can, and those exercises with the eyes and the C-spine and stuff like that can do so easy.
Yeah.
But like I said, the research around it is it has to be reactive. It can't be anticipated. So he can't look at the wall and say, okay, I'm looking at 12, I'm looking at 6, because he knows where he's going. It has to be something like that app that calls it out to him, and he has to react to it. And you can adjust the time, you can adjust the language, you can adjust all kinds of things to, to kind of increase the work through the system.
And that's the Clock Yourself app, Susan?
Yeah, it's called Clock Yourself.
Got it.
I think it costs $1.99 or $2.99 or something. It's not expensive, but it's great. And I, with some of my clients, I just say, it talks about doing everything on the floor because it's all, so tell him to just ignore all of that all he's going to do is put the clock on the wall, and just go through it that way. And when he gets really good at it and can, then once he gets good at his eyes moving, he can hold his eyes still in the middle and move his head to all the numbers. So the nose stays still, the eyes stay straight ahead, and the head moves up to 2. The head moves down to 7. Yeah, but the eyes stay fixed, so you can get both systems going.
Yeah. Also, one more thing: the chiropractor, does he? It's almost like he's enabling like his fear of, of being popped out, or something needs to get fixed. Is that something he wants to continue to do? Because that's not helping.
No, yeah. And he definitely says the chiropractor is much more of a gentle chiropractor. It sounds like he does a pretty low level segmental movement, and he says he just has his fingers on him. So I don't think he's doing anything major movement. But he definitely wants to reduce that, 1, from the drive, and 2, from the cost standpoint. So we had a period, I think he got 28 days without going, which was like a big distance. So right now he's only ended up going about it seems like he goes in these kind of streaks from the standpoint he does something, throws in a little more acute, and he goes maybe once or twice now, but then he'll have a good 2 to 4 week span between his visits at this point. So it's definitely reduced quite a bit, and he is very happy that that's happened.
Yeah. You need to celebrate those moments.
Yeah.
Yep.
Celebrate the streak and not the, okay, well, you had to go a couple of times, no big deal.
Yeah.
Instead of like, oh, see, because that's what they tend to do is like, see, I did this and this happened and I had to go.
Yeah, no, he's really
out. So why don't you be happy about that? Because you were going 4 times a week or whatever he was doing. Yeah.
And that's actually how he's kind of self-monitoring now, is how frequently he's going or not. That's his like mental, okay, well, I've done really well because I haven't gone for 2 weeks or 3 weeks. So
yeah, this is great. I mean, this is a great case of like, started off with like back and abdominal pain, but his ultimate, which you treated fantastically, and at the end of the day, it's his fear of movement and getting him to do some movement, and that's breaking down the movement patterns and looking at his history with a concussion. I mean, I think that's going to be brilliant for you. Do you have any other questions at all or anything?
No, that helps me a lot, because I was kind of sitting in this like, well, I've gotten you so far better, but I'm really feeling stuck. How do we get this next progression? And You know, I didn't even think about from the injury standpoint, the concussion. So I'm definitely really familiar with vestibular doing that stuff.
Yeah.
So that'll be easy to pull in.
Yeah, it'll all be good. But, you know, for everybody out there listening, I think the most important thing to understand here as we talk through this progression is that you have to meet people where they are. They come in. This guy was super complex, and the more history Elena uncovered, the more was there, right? And instead of taking them as roadblocks, all she simply did was she hit the biggest bang for her buck, which she said, you know what, let's just breathe differently. You know, and she got him to get, you know, to make some changes that way. She gave him some other things, but she actually went for the thing that he really wanted to talk about. He came in because of his abdominal pain. You know, he didn't know why he was there, but he was there. And so she helped him with that and got the buy-in with him. You know, that's a therapeutic alliance. She didn't do a whole lot to him, but she got the buy-in with him, you know, by going at the easiest, most powerful system you can go for. And nothing is more primal than breathing. Nothing. And so when you can get in there and start to change that and get some variance around that pattern, things started to change. But his trust in Elena started to change too, because he was then willing to start working on other things that were really what were very important to him, especially now that this was out of the way and he didn't have to worry about the abdominal pain or think about hernias anymore. He was able to move forward and start thinking about other things. So this is a great example of how you can get a complex patient down the road, and, you know, but it's, you know, you have to take it one step at a time or one system at a time to move forward. You can't do everything all at once. It's just not going to work. It's too much.
Yep. Yeah, and I agree. And just to empower him with movement and just come up with a couple of those reset self-checks just to give him, you know, to put him in control, because that's what he likes to do, right? You know, so.
Play to his strengths.
Exactly. Exactly. On that note, anything else, Elena?
No, thank you. That's great.
Cool. Wonderful. Thank you for joining us today and sharing this interesting case, and also your interesting and very complex clinical reasoning as you went through this case with us today. Greatly appreciated.
Yeah, it was fantastic. We all learned. It was awesome. Cool.
Okay, everybody. Have a great day today, and we will see you back on our next episode of Tough to Treat.
Bye.
Thank you.
Thank you, everybody.